study of teratogenesis, okay? And then you need to explain the principles of teratology. So there are 5 principles of teratology that you need to know, okay? And describe with examples anomalies caused by genetic factors, chromosomal abnormalities, and environmental factors. So these are all your teratogens. And describe the commonest methods of prenatal diagnosis. So how do we diagnose, how do we investigate someone with that you suspect of having some abnormalities, okay? The fetus with abnormalities, and then describe briefly the possible fetal therapies. So fetal therapies we're not going to touch on a lot because it's very subspecialized, okay? But you just need to know a little bit about it to be exposed to it a bit. Okay, so teratology is the science of a science that studies the causes of birth defects and congenital malformation or congenital anomalies. So the study itself is teratology, and teratogenesis is the production or induction of malformation, especially of a developing embryo or fetus. Okay, so teratogenesis is the process of how that happens, and teratogens are the causative agent, okay, the factors. So major structural anomalies occur in about 3% of live-born infants. So out of all the infants that are born alive, 3% of them will have major structural anomalies. And birth defects contributes to about 25% of infant death. So it's quite a major cause of death in less than 1-year-old children. Okay, like I mentioned, teratogens are the factors that cause anomalies, the causative agents. And persons with birth defects, 40 to 45% of them, a majority of them, you don't know what is the reason behind the birth defect. So there's no known cause. Okay, but 28% of them will have about a genetic factor to it, okay, chromosome abnormalities and mutant genes. 3 to 4% is caused by environmental factors. And 20%.
Excuse me, doctor.
Yes.
The screen, actually, the slides are in the first slide, doctor, the title.
It's not moving?
Yeah, it's not moving.
Wait, let me just do this here. New. Is it appearing? No. Okay, can you see it? No, wait, I haven't shared it. Share. Okay, how about now?
Again, doctor.
Okay. All right. So birth defects, again, for the majority unknown, 28% genetic factors. Okay, so it can be either the chromosome itself is abnormal or the gene has mutated. Okay, 3 to 4% is caused by environmental, but mostly I think it's multifactorial, where you don't know the reason, you don't know, it's multifactorial in that you have both genetic component and environmental influences. Okay, 0.5 to 1% is screening. Right, minor anomalies happens in about 15% of newborns, so it's quite prevalent. 15% of newborns, about 15 out of 100 newborns. And minor anomalies include microtia, pigmented spots, and short palpable fissures. So usually minor anomalies is not detrimental to health. It does not cause any major alarms, okay, major issues with the child. But when you find a minor anomaly, this will actually be a sign that the baby might have a major anomaly or major malformation. So you have one minor anomaly, you have a 3% chance of having major malformation. But if you find that the baby that you do a postnatal check on has 2 minor anomalies, then there's a 10% chance that the baby might have a major malformation. If there's 3 minor anomalies, 20% chance. So even though it does not cause any problems with the baby itself, but it's sort of like a sign that you have to look for major defects, because when a baby has a minor anomaly, it has a higher chance of having a major malformation because it can occur together. So minor anomalies is fine, but don't forget that you find one, you have to look for any kinds of major malformation, be it a heart issue, a cardiovascular malformation, be it, you have to check all the systems of the body to ensure that everything is okay, no major defects. All right, so there are 5 types of abnormalities that you have to know. One is malformation. So malformation is occurs during formation of structures. So when you're in the embryonic period, in the organogenesis period, okay, when the structure is forming, and then you have a problem with that, that's malformation. So one structure could be either complete or partially absent, or even then you have an abnormal formation of the structure. Say, like the kidney. So sometimes as the organogenesis is occurring, okay, as it's forming, sometimes you can have a baby who doesn't have one kidney. Okay, so it's complete absence of a structure. Sometimes the kidney, it develops, but it doesn't develop fully. Okay, so there's a partial absence of the structure. And sometimes the kidney will have an abnormal configuration, an alteration to its normal structure. Okay, so either it be complete partial absence, or it will alter the normal configuration itself. So instead of having a normal kidney, you have a horseshoe kidney, or you have a pelvic kidney. So there's an alteration to its normal configuration. And this can be caused by both environmental or genetic, or even both. Okay, it can be multifactorial. And a lot of malformation occurs during the 3rd to 8th week of gestation, because this is the embryonic period. Okay, and this is where malformation often occur. Okay? So malformation occurs when you are producing something during the formation process. Whereas disruption occurs on already formed structure. So there'll be morphological alteration to structures that have already formed. An example of this, as mentioned earlier in the previous lecture, is amniotic bands. Okay, so if you have amniotic bands occurring, okay, and you have like a fetus with a nice of already formed limbs, okay, this amniotic band can encircle it and can cause amputation. So this is alteration to already formed structures by destructive processes. This is called disruption. So when you have a limb amputation due to amniotic band, we don't call it malformation, we call it disruption. All right. Whereas deformation occurs when, yes.
Sorry to interrupt. I wanted to ask earlier, is there any possibility of detecting the amniotic bands before they cause major disruption?
We'll be looking at that in diagnosis. Okay, if you just hold on a second, we'll be looking at prenatal diagnosis. But usually it's quite difficult to look for it. Okay, to look for amniotic band, because it's not something that you can visualize with an ultrasound.
Okay.
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 All right. So other than malformation and disruption, you can have what is known as deformation. Okay, so deformation results from mechanical forces that will occur over a prolonged period. So these mechanical forces that occur over a prolonged period, it can mold a part of the fetus to be deformed. All right. So for example, when you have club feet, okay, this occurs because you have oligohydramnios. You have reduced amniotic fluid. So when you have reduced amniotic fluid, your limbs will be compressed, okay, especially the part of the feet will be compressed, and this can cause the feet to grow or to mold into what is known as a club feet. So deformation often occurs in the musculoskeletal system, okay, because mechanical forces that occurs over a prolonged period of time, it molds the musculoskeletal system more often than not. Okay, And this type of deformation, it can actually be reversed postnatally. So you have a baby that's born with club feet, we can do surgery or put it in casts to ensure that you can reverse the club feet after the baby has been born. Okay, so that's deformation. And then you have syndrome. So malformation, disruption, deformation, and then you have syndrome. Syndrome is when you have a group of anomalies that occur together and you know the specific reason behind it. So there's a specific common cause. So when you have a syndrome, it indicates that the diagnosis is known and the risk of recurrence is also known. So it's a well-studied phenomena. An example of syndrome is like your Down syndrome, where you have trisomy number 21, trisomy of chromosome 21. So you know what is the cause behind the syndrome. Okay, and syndrome is also, it's like a collection of all the clinical features. So you know, with Down syndrome, the patient often has congenital heart disease, and then you have multiple uh, craniofacial abnormalities, which include, you know, your epicantic eye fold, short nose, flat head. So a lot of these craniofacial abnormalities, along with your congenital heart disease, hypotonia. Sometimes you can have mental issues as well. So you have all these lists of signs and symptoms that you know often occur together, and you know all of this is due to trisomy 21. So you know the common cause, and you actually also know the risk of recurrence. So it's a well-studied clinical features. Okay, other syndromes include Patau, Edwards, Klinefelter. So that's syndrome. It's a collection of signs and symptoms with known specific common cause, and you know the risk of recurrence, and you know the diagnosis as well. On the flip side, you have what is known as association. So for syndrome, you know the cause, but for association, you don't know what is the cause. But the collection of anomalies is it occurs more often than what chance would permit. So it's a non-random kind of appearance of anomalies, and you don't have any cause, and you don't have the diagnosis, and you don't know the risk of recurrence. So you don't know, you know, sometimes you think it's just a random, but it occurs more frequently than just by chance. So it has to be sort of like there's a cause, but you haven't really found it yet. So the type of association that you have is vectoral association. So that vectoral stands for vertebral, anal, cardiac, tracheoesophageal, renal, and limb anomalies. So there's no diagnosis, but once you recognize one anomaly, it makes you look for other anomalies as well, because it often occurs in association with each other. So if you have a patient with a renal issue, okay, you have a baby with renal issue, you look for the other VACTEL as well. Okay, so you look for vertebral anomalies, anal anomalies, cardiac anomalies. Okay, so this occurs in association. It's just not yet, you just haven't found a common cause, so you haven't found that it's part of a syndrome. Okay, it's just an association. So those are the 5 types of or rather the 5 types of abnormalities that you have. Okay, malformation, disruption, deformation, syndrome, and association. Now we're going to move on principles of teratology. So principles of teratology, also you have 5 principles that you have to know. Okay, principle number 1 is susceptibility to teratogenesis depends on the genotype of the conceptors. Okay, so the genotype of the conceptors will also determine the manner in which this genetic composition interacts with the environment. So a big part of your principle of teratogenesis depends on it says that whether you are susceptible or not to the process of teratogenesis depends on the genotype of the conceptors. So you have a maternal genome that will contribute to drug metabolism, resistance to infection, other biochemical and molecular process that will affect the conceptors in terms of being susceptible to teratogenesis or not. Okay, so again, the genotype is very important. The second principle is susceptibility to teratogens varies with the development stage at the time of exposure. So depending on when you're exposed to a certain teratogen, Okay, and that would determine whether you will go through the process of teratogenesis or not. Okay, and the most sensitive period for inducing birth defects, as we know, is during the period of embryogenesis in the 3rd to 8th week. So there are certain teratogens that if you are exposed to it during the process or during the period of embryogenesis, that would lead to teratogenesis. But if you're exposed to, say, like the 35th week of gestation, then you are quite safe from the from developing teratogenesis. But again, um, different types of teratogen will have different types of different timing where it can induce teratogenesis. So no stage in gestation is the safest. No stage of development is completely safe. So there are certain teratogens that can also affect a well-developed fetus in near the uh, 3rd trimester or late in the 3rd trimester, as there are a lot more teratogens that can affect a fetus or an embryo in the early weeks as well. So you can't say that, oh, I'm in my 3rd trimester, I should be fine. Okay, or in my 2nd trimester, nothing's going to happen to the baby. There's no safe stage of development is it's completely safe. Yeah. And each organ system may also have one or more stages of susceptibility. So in cases like cleft palate, okay, it can be induced either in day 6 during the blastocyst stage, or in day 14 during gastrulation, or even in week 5 when you have the early limb bud stage, or even in week 7 when you have palatal shelf forming. So one um, abnormality can have multiple times where it is susceptible to producing to be abnormal. The third principle is that manifestation of abnormal development depend on dose and duration of exposure to teratogen. So if it's something like, say, the teratogen would be smoking. It depends on how much the mother smokes or how long the fetus was exposed to smoking or alcohol or infection or even hormones. So it all depends on the dose and duration. Okay, certain teratogens will, if you take it just a little bit and not for long, it'll be fine. Certain teratogens, not really. Sometimes you have to take a lot and for a long time for it to impact the fetus. So it all depends on the dose and duration of the exposure. And teratogens also affect in specific ways. So there's specific mechanism where the cells and tissues will initiate abnormal embryogenesis. And this can be as minute or as small as involving inhibition of specific biochemical or molecular process. So very, very small biochemicals, very very down to the molecular level, or it can involve a bigger kind of mechanism where it involves cell death, okay, a decreased cell proliferation, or other cellular phenomena. So it can be at a molecular level or at a cellular level. It can be small or big, but there's specific ways for each teratogens to act to initiate abnormal embryogenesis. And lastly would be manifestation of abnormal development are death, malformation, growth retardation, and functional disorders. So these four results is the only four results that you can have from manifestation of abnormal development. So either death, malformation, the growth retardation, or functional disorders. These are the four results from teratogenesis. Okay, and those are the five manifestations of teratogenesis. 5 principles of teratogenesis. Sorry. Now we're going to look at the teratogens itself. So you have environmental factors and genetic factors. Environmental factors, you have these 8 major classes. Okay, so infectious agents, radiation, chemical agents, hormones, maternal disease, nutritional deficiencies, hypoxia, and environmental chemicals. So these are the 8 major classes. You can divide the teratogens in 8 environmental factors that you can divide the teratogens in. Okay, so for the first class is infectious agents. It all has a lot to do with virus, okay, but also some bacteria as well, all kinds of pathogen that um, uh, abnormalities, okay, that can cause teratogenesis. So first you have your Rubella virus, your CMV, your HSV, the varicella, which is your chicken pox, Okay, HIV, toxoplasmosis, and syphilis as well. So all this can cause abnormality in a growing embryo or growing fetus. For rubella virus, okay, you can cause so all this virus can cross the placental barrier and can affect the growing fetus and growing embryo. So for rubella, you can have a lot of malformation occurring. So eye malformation, internal ear, heart, brain abnormalities. Even you can have a problem with the growth of the fetus itself. So you can have what is known as intrauterine growth retardation. All right, I'm not going to quiz you on all this, what rubella virus can cause or what cytomegalovirus can cause. That'll be a bit too much for you to remember for each virus. But this is just to show you that one virus can have multiple effects on the growing fetus. Okay, it can cause problem with the central nervous system. It can cause problem with the cardiovascular system, with the GI system. So not one virus, it doesn't mean that one virus is cause problem with the eyes, or one virus is cause problem with the kidney. Okay, it's a multi-systemic problem that it can cause in a growing embryo and growing fetus. So varicella, okay, the chickenpox is very important that it does not occur in the first trimester. Because if it does occur in the first trimester, then it's 20% chance of congenital anomalies. So again, first trimester is very sensitive when you have the embryogenesis and organogenesis occurring. Okay, so just go through all this. Okay, toxoplasmosis is caused by the bacteria Toxoplasma gondii. Okay, and syphilis is from your Treponema pallidum. All right, also can cause congenital deafness or mental retardation. Okay, so again, I won't quiz you on specific virus and what are the effects of the virus. This is just to show you the multi-systemic problems that a single virus can cause. All right, second class is radiation. So radiation, you can get microcephaly, skull defects, spina bifida, blindness, cleft palate, or even genetic mutations. Okay, so radiation occurs in various ways. Okay, either this is especially a lot of studies have been done in those who were exposed to radiation in terms of those pregnant ladies who were in Chernobyl disaster or in Hiroshima, Nagasaki. So you have a lot of that's a very, very high exposure to radiation. Other than that, you can also be exposed to radiation when you do, your X-rays. Okay, that's why before you undergo X-ray, if you're a female, you have gone through this, they will always ask you whether you have any chances that you're pregnant. And usually, if you're sexually active, they would ask you to do a UPT, urine pregnancy test, is to ensure that, because sometimes in your first trimester, you are not aware that you're pregnant actually. So if you do a UPT, then you're negative, then you can go for your X-ray. If not, usually they would not encourage it, of course, because of the multiple problems that can arise from exposure to radiation. Another class is chemical agents. So chemical agents include, your drugs, alcohol, smoking, okay, cigarette smoking, and also thalidomide. So thalidomide was actually a what do you call it, in the 60s, I think, not 70s, I think in the 1960s, doctors will actually prescribe thalidomide for morning sickness, for your hyperemesis, okay, for your nausea and vomiting in the early months of pregnancy. And during that time, they don't know that thalidomide can actually cause malformation in terms of amelia and micromelia. So amelia means you don't have the limb, micromelia means you have small limbs, right? So thalidomide, it affects the kind of malformation that occurs is in the musculoskeletal system. So eventually they found out that there was a high incidence of amelia and micromelia during that time. And when they tracked it down, they saw that a lot of these mothers took thalidomide in the early parts of the pregnancy. So now it's been, it's no longer obviously prescribed to mothers, to pregnant mothers. Okay. Other than that is exposure to cocaine. Okay, that can cause spontaneous abortion, intrauterine growth retardation, microcephaly, where you have small head, okay, neurobehavioral problems, and then with alcohol, you can have fetal alcohol syndrome. So mothers are always told not to smoke, obviously, not to do drugs, and also don't consume any alcohol during pregnancy. And then exposure to hormones, okay, either with a mother who takes androgenic agents, okay, you can have masculinization of external genitalia, or if mothers take oral contraceptives without knowing that they're pregnant, okay. Maternal disease such as maternal diabetes, okay, or phenylketonuria. In maternal diabetes, you can actually cause a high incidence of stillbirth, neonatal deaths, and abnormally large infants. Okay, abnormally large infants as well as congenital malformation. So with mothers who are already diabetic, or with mothers who develop diabetes during pregnancy, you have to. It's very important that you have to monitor their blood sugar level. Okay, sometimes you have to do a BSP, a blood sugar profile, 4 times a day to ensure that the level of glucose in the blood is well controlled. If not, you have a lot of these problems. Stillbirth, neonatal deaths, these are all not optimal or not wanted result from pregnancy. Okay, so always ensure that mothers with diabetes, you control it as much as possible. Some mothers are okay with controlling it by diet itself, reduce the amount of sugar intake, but some mothers have to actually take insulin, which is fine during pregnancy as long as you are able to control the blood sugar level. Okay, with mothers with phenylketonuria, sometimes you can have babies that are born with mental retardation, microcephaly, or even cardiac defects. In mothers with nutritional deficiencies, okay, the baby can with iodine deficiency, you can have stunted mental and physical growth, so cretinism in a baby, or poor maternal nutrition will result in low birth weight babies or other birth defects. So low birth weight babies is well, itself is quite explanatory when the mother is not eating enough nutrition. So not enough nutrition will also go to the babies, and therefore the babies will not be able to, or the fetus will not be able to grow as optimally as it should. Okay. Hypoxia will also result in low birth weight babies. So if you have any mothers with any respiratory tract problem, you ensure that they are well controlled when they are pregnant. So just to ensure that the fetus will get the optimum level of oxygen. And other environmental chemicals include mercury and lead. Okay, mercury will result in neurological symptoms resembling cerebral palsy, or lead will increase in abortions, growth retardation, and neurological disorders. So obviously, no pregnant women would intentionally ingest mercury or lead, but this could be, when you eat a lot of, especially raw fishes in waters that have high levels of mercury and lead. Okay, then that could be, if you eat a lot of the fishes or the seafood in that area, then you can also get increased level of mercury and lead in the maternal blood, and therefore in the fetus as well, and can cause all these abnormalities. So that is something to be mindful of as well. All right, so those are the environmental factors, the 8 classes that you have to know. For genetic factors, it depends on whether it's a chromosomal abnormality or a mutant gene. Okay, so mutant gene is just one gene that has mutated. Okay, whether you have dominant kind of mutation or recessive mutation. And for chromosomal abnormalities, it depends whether it's kind of like the number of chromosomes that's a problem, where extra one chromosome sort out 5 abnormality will result in a certain syndrome. Okay, we'll be looking at that. So for chromosome abnormalities in terms of numerical abnormality, okay, so we know in humans we usually have 23 pairs of chromosomes, so that gives you 46. So there'll be 22 autosomal chromosomes and 1 pair of sex chromosome, be it XX or XY. So XY is for males and XX is for females. So sometimes when we go through gametogenesis, okay, when we produce gametes, in female, you produce your secondary oocyte. In male, you produce your sperm. You can have what is known as non-disjunction. So non-disjunction occurs when there's failure of chromosome pair or two chromatids of a chromosome to disjoin, either during mitosis or meiosis. Okay, so when this occurs, you have this non-disjunction during gametogenesis, and you have an aneuploid number of chromosome in a cell. Okay, so aneuploid means that it's not an exact multiple of the haploid number. So your haploid number is 23, but your chromosome number is either 45 or 47. It's not times 2. So in aneuploid, you have either trisomy or monosomy. So trisomy is when you have 2n, 223, which results 46 plus 1. So you have an extra 1 chromosome. In monosomy, you have a reduction in chromosome. So it's 2n minus 1, which means you only have 45 chromosomes. Okay, so this is sort of like the example of the non-disjunction that can occur. So you can see that there's one chromosome that does not separate. And when it does not separate, it will result in a daughter cell that's 22 plus 2 plus it should be 23 plus 1. Sorry, it should be 23. So, but this one you have 22 and then you have another 2 extra. So this results in 24 chromosomes. So when you have this in your oocyte and you combine it with an oocyte that has 23 chromosomes, it will give off a zygote that has 47 chromosomes. You have an extra chromosome for the zygote, for the fetus itself. So they say that as much as 25% of conceptions actually involve chromosomal disorders. First trimester, a lot of women will undergo abortion, okay, natural loss of the baby, because a lot of conceptors with chromosomal abnormalities will actually undergo abortion. So these are all mostly lost, and only 0.6% of the conceptions with chromosomal disorders will be carried to term. Okay, and of the most recognized trisomies are trisomies 21, which is Downs, 18 and 13, Patau and Edwards. These are the only autosomal trisomies that are compatible until birth. But only trisomy 21, your Down syndrome, will have a very high chance of life beyond infancy. 18 and 13 will also usually, most of them will pass before their first birthday. Okay, so trisomy 21 Down syndrome is the most common trisomy because it is the only trisomy that is compatible with life beyond infancy. So you have an extra copy of chromosome 21. All right, so karyotype, be it 47XX plus 21 for female or 47XY plus 21 for male. All right, so symptoms involve growth retardation, mental retardation, craniofacial abnormalities, cardiovascular abnormalities. So there's a lot of syndromes that you have. These craniofacial abnormalities include, short palpable fissures, upward slanting eyes, flat head. We also have hypotonia in the babies, and 95% is due to meiotic non-disjunction. So the non-disjunction occurs during gametogenesis, during meiosis, not during mitosis. Okay. And there's an increased incidence of trisomy 21 in older women. So if you have a mother that comes to you with advanced maternal age, you most often than not, you advise them to undergo screening to see whether they carry a baby with trisomy 21. Trisomy 18 is Edwards and trisomy 13 is Patau. Okay, you can also carry the fetus to birth, but they usually don't survive their first birthday. Other than autosomal extra chromosomes, you can also have a sex chromosome that you have extra, like in Klinefelter syndrome, where you have extra X chromosome, so it becomes 47XXY. This will give the baby male genotype, okay, but the person will be sterile because you have of this extra X chromosome. You're not able to produce sperm that can fertilize a secondary oocyte. Okay, so that's trisomy, where you have extra chromosome. In monosomy, you have the absence of chromosome. So in Turner syndrome, you have the karyotype 45X dash. Okay, so you don't have you have lost or missing an X chromosome on the sex chromosome pair. So what happens to the individual? They have absence of ovaries, okay, making them sterile as well. Short stature, web-necked, and all the other features that you can see in the picture as well. So this is called Turner syndrome, and the individual is usually female. All right, that is the numerical abnormalities. For structural chromosomal abnormalities, you have in terms of like chromosome 5, where you can have a partial deletion of the short arm. So it's not the whole chromosome that's a problem, it's just a part of the chromosome that's a problem, the structure of the chromosome. So in Credushaw syndrome, where you have the short arm of the chromosome 5 is partially deleted, so you can have all these clinical features, okay, microcephaly, mental retardation, congenital heart disease, and cry of the babies is what they call cat-like cry. That's why you call it the Credushaw syndrome. Okay, so those are the two kinds of teratogens that can affect or that can lead to teratogenesis, be it environmental or abnormality, like environmental or genetic. Okay, genetic can be either chromosomal or you have mutation of the gene itself. So chromosomal, you have numerical or structural. For the gene mutation, okay, it can be it occurs usually in in sporadic manner. It's very difficult to determine. You have to look at the patient and the presentation. It's more like it doesn't occur very commonly. Okay, so that's why I didn't touch that much on it. And then for environmental factors, the 8 categories that you have to know, from environmental, infection, radiation. So all that is all your environmental factors that can cause teratogenesis, environmental teratogens. Okay, so now we're going to look at prenatal diagnosis. Okay, what are the modalities that you can use to ensure that the baby or the fetus is growing as it should. Okay, so when a prenatal diagnosis or the modalities that are used for prenatal diagnosis is indicated, especially in high risk pregnancy. Okay, so when you have advanced maternal age, when you have pregnant mothers that are more than 35 years old, we have family history of previous child with neural tube defects. Okay, previous gestation with chromosomal abnormalities. Also, you always offer prenatal diagnosis modalities. And then when you have one or both parents that are carriers or have the disease of X-linked or autosomal traits. Okay, so these are disorders that can be passed through families, like you have parents with thalassemia or you have parents with hemophilia. So these are the things that you always also would offer to investigate. Or you have a mother who have a history of recurrent miscarriages. Okay, previously 2-3 miscarriages that the pregnancy that she carried resulted in miscarriages. So you also offer these are all known as high-risk pregnancies that you would offer a lot more attention and a lot more investigations to them. So these are the 4 modalities that the ultrasound, maternal serum screening, amniocentesis, and chorionic villus sampling. Okay, so the least invasive is obviously ultrasound. So ultrasonography you can use to produce images of placenta and the fetus is the least traumatic, least invasive. Okay, and what you can see through ultrasounds is placental and fetal size. Okay, so you can see the location of the placenta. Remember, if it's located quite low in the uterus, in the lower segment, or sometimes it can cover the internal os, that's placenta previa for you. So you can determine the placental location, the placenta size. You can look at the fetal size. Okay, you can look at the position of the fetus. And if it's early on in the gestation, you can look at a number of gestational sacs. Okay, so you can know whether it's one pregnancy or multiple pregnancy, and sometimes you can also look for malformations. Right. So when you do this, when you do ultrasound, okay, usually if it's like before the 8th week, most often than not, you have to do a transvaginal ultrasound. That means you do the ultrasound through the vagina. But after that, as the conceptus grow bigger, we can do a transabdominal ultrasound, which I think everyone is quite familiar with. It's always depicted in the movies of a transabdominal ultrasound. And you can also do detail scan. This detail scan is the one that can catch any malformation. Okay, so detail scan usually you do about 20, 22 weeks of gestation. Okay, this is for you to be able to see in detail all the systems of the baby. Okay, you can check for neural tube defects, anencephaly, spina bifida, cardiac, abdominal wall defects. You can look for cleft lip and palate as well. You can look at the kidneys, look for renal atresia. So detail scan is better. A lot of times nowadays it's offered to all pregnancies, okay, to ensure that everything is just working fine. Another method ultrasonography can also offer is what is known as the nuchal translucency test. So this nuchal translucency is to screen for Down syndrome. So when you have a baby with Down syndrome, when you have a fetus with Down syndrome, you can actually a lot of fluid actually accumulate in the posterior part of the baby's neck, okay, at the posterior side of the neck. And when you do an ultrasound, you can measure the width of the or you can measure the amount of the fluid. Okay, you measure the amount of fluid by looking at how thick the fluid level is. Okay, so fluid in ultrasound, it appears black, and the other body parts will appear white. So you can actually measure the fluid amount, and it can be a screening for whether you think it's if it's thick, then you can say, oh, it is maybe ultrasound. So you can confirm it by doing a different kind of procedure. Okay, so this is like a screening for Down syndrome, and this test is performed about 11 to 14 weeks of pregnancy. Because if it's too early, you can't measure it properly. If it's too late, also, so the window is just 11 to 14 weeks of pregnancy where you can do the nuchal translucency ultrasound test. Okay, so ultrasound, you can see in the first picture. Okay, that's about a 6-week embryo. In lateral, in the picture B, that's the lateral view of the fetal face. Okay, as the fetal face, you can see the fetal head and also the fetal feet. Okay, but what is also important about ultrasound is to do it serial ultrasound. Okay, so serial ultrasound means to do multiple ultrasounds at different times of gestation to see the growth rate of the baby, whether it grows according to the chart. Okay, grows nicely. That's how you can also determine the growth of the fetus. So to measure the growth of the fetus, you usually measure a few measurements. Okay, if it's less than 8 weeks, usually you measure the crown rump length. So this is about a fetus about the 7 weeks. So you measure between the top of the head to the bottom of the butt. Okay, so that's the crown rump length of the fetus. But as the fetus is bigger, okay, you can measure the 3 measurements that you take. First is your biparietal diameter. That's to measure the head circumference, okay? And then this is the abdominal circumference. And then you actually also look for the femur. That's the femur there, to measure the femur length. So you compute all of this together. Usually in the ultrasound machine, you can just measure the length in centimeters or the diameter in centimeters, and it will give you the reading whether it's up to date. Okay, if the pregnancy is at 20th week of gestation, and then all the measurements are according to what a 20-week fetus should be measured at, so all is good. Okay, you can also look at it serially. You can look at 1 month ago, this month, next month, see how the fetus is growing, whether it's growing according to the rate that it's supposed to. Okay, so these are the measurements that you take, okay, for when you try to measure the growth of the fetus. this is the when you can measure the number of fetus. Okay, you can actually see two gestational sacs there. It's quite different. It's quite difficult to see the embryo proper. You can just see the two sacs of the embryo. Okay, so other than that, ultrasound can also reveal the gender of the fetus. Okay, you usually do that about between 16 to 20 weeks. You can see the gender as long as the baby does not cover the groin area. And nowadays, with the advancement of technology, you have 4D, 5D, 6D scanning um, for the ultrasound that you can do. Okay. Other than that, ultrasound, you can also apply Doppler technology, so you can see the blood movement depending on the the speed of the waves that are moving. So you can also look for any uterine placental insufficiency, any problem with the cords. Okay, so these are also things that you can do with ultrasound as well. Okay, so to ask about your amniotic bands is quite difficult to visualize. Okay, because as you can see, a 3D black and white ultrasound, 2D ultrasounds are actually just as good. Even the 3D, 4D, 5D, 6D, it all actually it's just software manipulation of your 2D ultrasound. It's just how they read the ultrasound, how they use software to build upon the 2D ultrasound. So no, amniotic bands, it's very difficult for you to diagnose, very difficult for you to see, unless of course if it has affected quite badly, where you can see the baby and then see that, oh, why is in the femur or constriction in the leg. Okay, so that's when you can also see the problem. But usually, it's not something that we look for. Amniotic bands also, although I mentioned it quite a few times, it's not as common as one would imagine. It happens, but it's not very common, and we don't actually routinely check for it. Okay. Um, so after ultrasound, you can also do maternal serum screening. So maternal serum screening, it basically you take the blood of the mother and you look for alpha fetoprotein concentration in the maternal serum. So why do you look for AFP in the maternal serum is because at about AFP is actually by fetal liver. Okay, and it peaks at about 14 weeks, and it will go into the maternal circulation. So it will leak into the maternal circulation, and there are certain abnormalities that can cause an increase or a decrease in alpha fetoprotein. Okay, so an increase in alpha fetoprotein is developmental abnormalities of the central nervous system or GI tract, or it will be decreased in Down syndrome, in trisomy 18, in sex chromosome abnormalities by the triploidy. So you can look for this, especially this is usually offered with mothers with advanced age or mothers who has had pregnancy with chromosome abnormalities. So you can look for this with you usually do maternal serum screening with this kind of mothers. You don't usually do it for everyone. Okay, so this screening, it provides a non-invasive technique for the initial assessment. So first you do an ultrasound, you see, oh, nuclear translucency is actually increased, and then you do the maternal serum screening, and you can see the alpha fetoprotein is decreased. So slightly scared of it being Down syndrome. So all of these are just screening. It's not yet diagnostic. Okay, it's just screening. It points towards something, but it's not okay, definitely Down syndrome. So you can then further move on to amniocentesis. So amniocentesis is when you insert a needle in the mother's abdominal cavity and uterus, and you introduce the needle all the way into the amniotic cavity. When you introduce in the amniotic cavity, you can withdraw about 20 to 30 milliliters of amniotic fluid. Okay, and you can only do amniocentesis about 14 to 15 weeks of gestation, because before this you don't have enough amniotic fluid. Okay, and we need quite a bit of the fluid. We need about 20 to 30 mils. That's quite a lot. That's like a big syringe worth of amniotic fluid. So if you do it prior to 15 weeks, you're not able to get that much fluid. And if we take too much fluid at that time, then it's not good for the baby itself. So the fluid is then analyzed for alpha fetoprotein as well. Okay, because an increase in amniotic alpha fetoprotein can be when you have open neural tube defects. Okay, so these are your your central nervous system abnormalities, and abdominal malformations when you have your GI tract abnormalities. And what else can be found in the amniotic fluid is you can actually find fetal cells in the amniotic fluid. So because the fetus is located in the amniotic cavity, okay, it's suspended in your amniotic fluid. Okay, the cells of the skin, the cells of the baby, the cells of the fetus will slough off sometimes, and these cells are located or are suspended in your amniotic fluid as well. So when you take enough amniotic fluid, you can actually find fetal cells in there, and you can grow it, and you can analyze it for chromosomal abnormalities. So you can do your karyotyping on the fetal cells, and you can actually look for chromosomal abnormalities. So when you karyotype the fetal cells, you can see, oh, it actually does have trisomy 21. So this can be a definitive answer to your previous suspicion when you do the nuclear translucency, when you do the maternal serum screening. Okay, you do amniocentesis, you find that you can get the fetal cells, you can karyotype that, grow it, karyotype, and you can get your answer. Okay, or the answer may be that, oh no, it was just false positive, so there's no chromosome abnormality. So this gives you a definite answer to that. Okay, then that's amniocentesis. So this is a picture of how amniocentesis is being done. Usually you do it ultrasound guided. Okay, so you do a transabdominal ultrasound, and you can guide the needle to just go at the amniotic cavity so that it doesn't hit the baby, and it goes inside the amniotic sac itself. Okay, so you can introduce it as much as possible into the amniotic cavity, and then you can withdraw the amount of fluid that is needed. Okay, so other than amniocentesis, more as we go more and more invasive, we can have what is known as chorionic villus sampling. Okay, remember all the villus that we talked about just now. Okay, so this chorionic villus sampling is when you take a small piece of the chorionic villus tissue. So basically, you're doing a bit of a biopsy of the chorionic villus. So we do this because the chorionic villus definitely will have the fetal cells, because the chorionic villus arises from the cells of the product of conceptus, okay, from the cytotrophoblast. Cytotrophoblast comes from the embryo itself. It doesn't, the product of conceptus is not from the maternal side. So when you do chorionic villus sampling, you can get the fetal cell, and you can also analyze it, karyotype it, and you can look for the chromosomal, and sometimes you can also analyze it for biochemical defects as well. So this would be, for when you have mutated genes, okay, that would cause inborn errors of metabolism, you can actually analyze it for that as well. Okay, and the advantage of doing a chorionic villus sampling as opposed to a what do you call that, amniocentesis, is that you can do chorionic villus sampling quite early in pregnancy. You can do it about 8 weeks of pregnancy. You can already do a biopsy of the chorionic villus. Whereas for amniocentesis, you have to wait to about, after 15 weeks, 14 to 15 weeks of gestation, only you're able to take the fluid. Okay, so there are certain times that we offer this, even though it's more invasive, but there are parents who, let's say previously they already have a Down syndrome baby, so they are trying again, and they want to allay their anxiety, so don't want to wait until 15 weeks. You can actually do it at 8 weeks of pregnancy as well. Also in certain society where termination of pregnancy is an option for them, they do it early on. They do the CVS early on, so they can know the result of the chromosome study, and they can opt for an early term pregnancy, because if they do they wait for amniocentesis, it will be, you know, later in the pregnancy that it will be already in the second trimester, they wouldn't want to, or they're not able to terminate the pregnancy. So although we don't really practice that in Malaysia, but it's something that is practiced in other society, in other countries, where termination of pregnancy is an option, and you do the CBS so that you can decide early on whether the pregnancy should be terminated or not. Okay, so this is a chorionic venous sampling. Okay, so those are the prenatal diagnosis that you have. Okay, ultrasound, and then you have maternal serum screening. You also have the amniocentesis and also the chorionic villus sampling. All right, now just about the fetal therapy, that I'm not going to elaborate so much again, because it's something very subspecialized. Again, as a houseman, you wouldn't have to really know all this. Okay, it's something that even an obstetrician, you have to be very subspecialized in the obstetric world to do all this. Okay, so one thing you can do is you can do fetal transfusion. Okay, in cases of fetal anemia that is produced by maternal antibodies. So sometimes you can have the maternal antibody that can attack the fetal blood. Okay, something like when you have a specific antigen for the blood. Okay, where you have the erythroblastosis fetalis or fetal hydrops, you can transfuse blood into the fetus. Okay, they would use ultrasound to guide the needle into the umbilical vein, and you can transfuse blood into the fetus. Okay, um, other than that, you can have medical treatment, fetal medical treatment. So this is given through the mother, and it will reach the fetus through the placenta. For example, is when you take folic acid before and during pregnancy, or you may be given through injection of the fetus via the gluteal region or the umbilical vein. Okay, so this depends on the type of treatment that you want to do. So like folic acid is quite important. So a lot of times, folic acid can protect from developing neural tube defects, although it's not 100% protection, of course, but it does reduces the incidence of neural tube defects. So a lot of times, when you are planning to get pregnant, you already take folic acid, because when you're pregnant, when you know that you're pregnant, you're usually about the 6-7 weeks of pregnancy. So at that time that you are aware that you're pregnant, actually embryogenesis has almost completed. And when so folic acid, although you continue to take it on, the most crucial part where it does help to protect the developing embryo is actually over. So usually when you have a couple that is already wanting to try to conceive, you would tell them to take folic acid early on before even conceiving. So transfusion, medical treatment, or you can do fetal surgery. Okay, so this is when you introduce a lot of laparoscopic devices into the uterus. So you do the ultrasound while you're doing the laparoscopic procedure as well, and this is known as fetal surgery. Okay, and other kinds of therapy is to do stem cell transplantation and gene therapy. Usually in fetus, they do not develop any immunocompetence before 18 weeks, so they don't really have any kind of immune system before that, even though you do get your IgG from your mother, but you haven't developed the immunocompetence yet. So you can actually transplant tissues or cells before that time without rejection, so you don't have to be worried about host versus graft disease or anything like that. They don't have any rejection because they don't have the immunocompetence of an immune system. You can transplant a hematopoietic stem cell for treatment of immune deficiency and hematologic disorders. And other kinds of gene therapy that you can do. Okay, gene therapy, it's a very, very highly specialized. Okay, but the diseases that you can help with gene therapy is those like Tay-Sachs and cystic fibrosis, which is actually not very common here in Malaysia. Cystic fibrosis, a lot of it happens in the amongst a Caucasian. Okay, so it's not something that we are very well versed on actually. Okay, any questions? Okay, so that is your teratogenesis and fetal birth defects and prenatal diagnosis. I think that was the last slide anyway. Yep. So no questions? All okay? If all okay, or or are you all still here? Here in name, not here in still here. Some of you are still here. Okay, so again I'll put the slides in the Teams, and I think that's all for anatomy. So yay, you're done with anatomy. That was the last class, wasn't it? So I think you have mock on, is it Thursday or is it tomorrow?
Yeah, Thursday.
It's Thursday.
Thursday.
Doctor.
Okay, so you have mock on Thursday, and then I guess you don't have any EOC or OSPE. That will happen once this whole CMCO is over, hopefully, inshallah. Okay, so if there's nothing, then congratulations for finishing your general